Well, good morning, and I'm really excited to talk about learning health systems and how they relate to implementation science. And JD, thanks for really setting the stage this morning. And as I shift gears, I'll talk a lot about one particular program, and that's the Quality Enhancement Research Initiative, and the lessons learned from Query about how you can basically work in a learning health system, use implementation science, and really get and speed that translation to research into practice. But from a personal perspective, a learning health system probably includes three essential things. And I'll talk a little bit more about what those things are. But one is really you have a group of people with a common goal that you want to solve, a common problem that you want to solve, kind of like what we talked about yesterday, essentially like improving outcomes in cancer or things like that. A second piece is you need to have data and governance, meaning that you need access to data, essentially population level data, and then basically the methods and mechanisms by which you can use and get access to that data on a routine basis and make sure that the data are fed consistently with more information over time. And then the third piece is you need to have a cycle in terms of thinking about doing both research and quality improvement at the same time. And how do you do that? Well, you have two lanes of effort. The research is deep dive into basically answering scientific questions. The quality improvement is basically supporting the community that you're working with and making sure that they get something in return. So basically a type 3 hybrid design, for example, a study like where you basically are testing different implementation strategies and basically promulgating an evidence-based treatment or practice is an example of sort of the best of both worlds. You're giving something back to the community, but you're also hypothesis testing around what is the best way to sustain it. So that's essentially in a nutshell what a learning health system is. And what I'm going to talk about is basically a high-level overview of what Query has done to build a learning health system in VA. Talk a little bit about sort of the lessons learned from that process. And then from an individual perspective, I just really want to acknowledge one particular mentor of mine who was Mark Bauer. And he actually basically commissioned that 2019 special issue on psychiatric research that included a bunch of articles about implementation science. So he was really one of the brain children, along with Jeff Kern and others, and Sarah Landis, who really basically published that to really get the message out about the importance of implementation science in a learning health system. So without further ado, you've probably heard this argument before, but if you think about, what was that, some movie came out like Indiana Jones, like 20th version or something like that. But I always remember this one from the early 80s, since I'm, probably dating myself here, about the last scene in the Raiders of the Lost Ark. And you work so hard as basically an interventionist, designing this intervention only to have it be shelved in some government warehouse. And so we know that it takes, a long time to get a fraction of stuff into the hands of people who need it the most. But basically, why we do implementation science and why we do it in a context of a learning health system is that basically public health and the world is essentially changing. We have to deal with the social determinants that are beyond the clinic walls. This is a picture from a neighborhood in the Detroit area. And, all the perfect types of implementation studies that are done will not be able to make any impact unless we basically deal with these structural issues. In addition, we also have to understand that a lot of behavior change and outcomes are driven by empowering patients and consumers. And so this is one example of some publications out there. This is a book about essentially how patients are really driving the healthcare decision-making. We also have to think about beyond the academy. It's a little hard to see here, but this is a storefront in Los Angeles. This is basically a storefront called a Clínica Bottega, which is a place where you can go for outpatient healthcare. And one of the unique features of this in this largely Hispanic community was they actually published the prices of preventative screenings and like breast cancer screenings and things like that. Price transparency was basically implemented by our immigrants before, the policymakers in Washington, D.C. tried to do this and essentially try to make it mandated nationally, even with the healthcare organizations kicking and screaming not to want to do it. But essentially, they had posted their prices for all the healthcare services. I mean, why not? And I think it really, in many respects, drove a lot of a demand and competition for healthcare in LA County. And then we also have the promises and pitfalls of information technology and the potential biases around the use of so-called artificial intelligence. Essentially, if you don't have good data, you're not going to get good outcomes. And then finally, thinking about the unknown unknowns. And we heard about COVID and basically going from efficacy to type 3 in a whirlwind, and essentially those kinds of opportunities or challenges in both are going to be coming up again and again. And really just thinking about the systemic challenges and some of the work that others have written about the fact that, we can probably get healthcare to work better for us, but a lot of times it's these disincentives in the healthcare system that really challenge us to think about not just kind of doing incremental changes and getting effective treatments out to people, but basically changing some policies as well. So this is the disconnect between research and practice and why we basically need a learning healthcare system with implementation scientists and data scientists and all sorts of scientists embedded in the process. In turn, you think about it, it's basically how practitioners find out about research findings is not the same as how researchers communicate those findings. And so when you think about working in the learning health system, you have to talk to different audiences and basically help them understand what implementation science is all about. As a key example, when we talk about implementation science, which is a 5-syllable word in the VA with policymakers, we often talk about change strategies because they understand change strategies a lot more easily than grasping what, essentially what CFR components are, for example. So it's just things like that. Yeah, you just have to keep in mind when you're communicating. So why implementation science and learning health system? Why this is really the engine of what we do and how we do it. We are here to address key barriers to research to practice translation. Oftentimes, the research timelines are not basically the same as the needs of your community. When you think about first submissions, like you submit a grant or a paper, things like that, it could be several years before the actual publication. And decisions are made, like in the VA, about that are essentially done without waiting for the research to be published. And so you need a consistent cycle of research to be able to work with communities. You also have mismatched priorities and incentives. Leaders want specific and timely answers. And also, but at the same time, there's really a lack of incentives for community engagement. Up until recently, it's been very hard. You had to basically build your community engagement, build your learning health system before you get your first R01. Now I think the field is changing slightly and funders are realizing you need that sort of startup period to basically build your community support and the data you need to actually collect this information. And then also there's lack of planning for future scale-up and interventions. Essentially, what is the value proposition? What should be, why we have economic evaluation of implementation strategies? It's basically for operational leaders to understand what it takes to sustain something. And then you also want to avoid the helicopter research, which is traditionally has happened a lot, where you go into a community, do your study and leave and not really present back to them. It's a very one-sided thing, and you want to avoid that as well. So I'm going to kind of walk through sort of and take some time with this learning cycle conceptual framework. So this is Chuck Friedman's vision of a learning health system and how it works. And if we remember when I talked about the idea of a learning health system, you need to have that learning community, you need to have those processes and data, and you need to have a continuous cycle, a repeatable cycle. So imagine you are essentially forming a group of people where you have healthcare leaders, clinical managers and providers, the IT department or someone there who basically is in control of the EHR, for example, and patient and consumer family representatives and researchers. Those people together form what's called a learning community. That learning community shares a common specific goal, usually outcomes oriented, something like you want to basically improve the outcomes related to a specific patient population or a specific disease, or it could be just basically improving the wait times for the ER clinic or something like that. So you have that learning community focus on a particular health problem of interest. You come up with a shared goal or set of goals. And then what you first do is think about capturing the practice of what's going on right now in your healthcare system or your population, and you basically capture data and understand what's going on. So imagine, let's say you want to basically, and I'll just talk about an example throughout my research careers when I was very interested in improving quality care for people with bipolar disorder, that basically they were dying younger from suicide and cardiovascular disease. So the first thing that we did as a team was we looked at the VA national patient care data and tried to understand who was essentially most likely to die younger from bipolar disorder or from these other co-occurring conditions and figure out where were the gaps in quality. And we did that using administrative data. We also did that looking more deep dive into the electronic health record data. So you want to be able to capture what's going on right now using existing data. And then what you also are capturing, and that sort of green part of the cycle, that's performance to data, You're also trying to understand what other data do you need to actually better understand the gaps and also better understand, like what we talked about earlier, what changes if you basically introduce an implementation strategy, an intervention, or a quality improvement initiative. And then through data to knowledge, you basically assemble and enrich those data with other information. You might need to do surveys or mixed methods or basically algorithms used in your electronic health record. And basically you use those data as your cohort, and that cohort becomes your foundation for your intervention trials. These could be trials or studies, basically understanding what methods or treatments or care models might work to improve quality and outcomes of care for people. Or they could also be looking at existing evidence in terms of what kinds of medications or what is out there in terms of best practices, and maybe designing a hybrid type 1 design. And so that's your data to knowledge. You're generating new knowledge about what works. And then after you do your data analysis and you interpret the results, then you start the exciting part of planning what you're going to do about it. So you have some effective interventions, now what? Basically, that's where during this phase of knowledge to performance, that's all implementation. And it can basically be done in two branches. You can basically do direct quality improvement and maybe take something that could immediately improve the quality of care for people with their condition of interest, and you do a quality improvement intervention. You might also then do an implementation study where you basically look at ways in which you can design and test different ways of implementing an effective intervention. You might maybe, for example, if it's bipolar disorder, you may want to do a quality improvement intervention to improve the adherence and follow-up for people on lithium, as an example. For a implementation study, it might be, okay, how do I improve the use of the chronic care model for people with bipolar disorder? And so you want to be able to design a study that informs you about how to actually sustain a care model over time. But the idea is simultaneous marriage of the quality improvement work that you do, and then you have a parallel lane of effort for an implementation or related type of research study. Different protocols, of course. One goes to IRB, the other is basically direct quality improvement is designed to improve care at that time. And then you repeat the cycle by basically getting more knowledge and then figuring out, okay, where are the gaps? What are some of the unexpected outcomes that we may have found? Maybe there might be disparities in certain groups. And then you repeat the cycle, essentially garnering new data over time, new essentially effective treatments over time, and then you repeat it. But basically, this is all supported by an infrastructure. You need good access to data, and essentially be able to curate those data and then feed more information or feed more data into your data lake. And then you also need a governance. You need standard operating procedures for other investigators to work with you. And you need to also have the support of the leadership of the organization or community that you're working with. So essentially, those are the key components of running a learning health cycle or learning health system cycle. So I'll talk a little bit about the VA and a little bit more about the Veterans Health Care Administration and what Query has done to build and cultivate learning health systems for different areas of research, and also what some of the impact might have been. So just a quick snapshot for those of you who are not too familiar with the VA healthcare system. One of the things I should say right away is it's often been considered a different system from the rest of the world, like Kaiser's and places like that. But with legislation that allows veterans to choose VA or non-VA care, the world of VA is becoming more similar to Medicare and other places too. So I think in many respects there are more similarities these days and differences between the national healthcare system, i.e. VA, and then the private sector as well. But where we are now is we serve over 9 million veterans in over 1,200 facilities. We have a global budget of salaried providers. We also have a dedicated appropriation to research funding across the spectrum, which having an embedded research program in a national healthcare system is really key to making a learning health system work. We also have nationally academic affiliated training programs. So many of our investigators in a VA are academically affiliated, such as the folks here. We've had over 20 years of an embedded EHR, and also we've had an integrated system where we have not only a healthcare system, but a benefit system, for example, where we're able to study, for example, the impact of veterans benefits for housing or education, and also disability benefits these are dealing with social determinants of health on their healthcare outcomes as well. And the national program for implementation is Query. So the mission of Query is to improve veteran health by more rapidly translating research into practice. So we serve multiple roles as VA investigators. And so one of the first things we do, for example, in the query program is we are designed to work both with other researchers and with clinical operation leaders. And so the query program is designed to basically help investigators find operational partners and the policymakers, the people in charge of actually making care changes to VA and making sure that that investigator is embedded as a researcher within that policy program. So we matchmake, and that's one of our goals here. We also knowledge translate rigorous implementation and evaluation methods. And for the past couple of years, we've run several what we call learning hubs. And these learning hubs are designed to teach people how to use different implementation strategies. We also have a rapid response program, and to use all the VA acronyms here, a VISN is a VA integrated service network. That's like a healthcare system that's regional. But what we do is a lot of rapid response requests where people need results like within 6 months or even 3 months, and we assign it to a query center and they work on a quality improvement project. We also do a lot of training for frontline providers, and then we also collectively have made a lot of real world impacts on veteran care. So for example, these numbers are quite outdated. Immediate impacts for the past year have been on 500,000 veterans. Collectively, over the past 5 years, we've reached 5.3 million veterans and basically providing them evidence-based treatments. We've trained close to 27,000 VA providers in a single year to basically use these new effective treatments. We provided over 200 products and then also reached and provided additional funding for VA investigators on the order of 35 million. And our budget's really small, it's like 20 million, but we were able to actually get other funding through the government to provide VA investigators additional funding to do their implementation work. So this is a very complicated schema, but I wanted to show what our training effort system looks like, because one of the features of the VA is that we have that combination of being an embedded research program, and we train practitioners as well as researchers, and we're in a national healthcare system. So for data to knowledge, we have a number of postdoctoral fellowships like our advanced fellowship in learning health systems within our health services research program. For knowledge to performance, which is implementation, we have the implementation learning hubs, which train both practitioners and researchers on how to implement. So we have a learning hub, for example, on training people how to use implementation facilitation, for example. We also have the Diffusion of Excellence program that is basically allows frontline providers to submit what they call promising practices or effective treatments and be able to actually essentially via a Shark Tank format, actually pitch these new innovation ideas in front of VA facility leaders and also regional leaders. And then the Sharks actually vote on that they would promise to replicate those effective promising practices in other places. And so we've had actually a couple of them out of, I believe at the VA, Madison VA, that had gone to the finalist stage at this point. And then we also have a program called ADIL, or Advancing Diversity and Implementation Leadership, which is query funded, that provides support for up to 2 years for fellows who are either at, essentially at terminal degree level, like they're postdoctoral fellows, or they're actually staff members, advanced staff members who can get additional leadership training on how to implement, how to do a QI project, and how to do evaluation. So that's a unique program that Query offers as well for underrepresented populations too. But essentially, these are different training programs in all across the learning health cycle about how to learn, how to implement and evaluate in the real world. And this is all really foundationally based on the Query roadmap, which is foundationally based on the learning health system cycle. The idea about the Query roadmap, as discussed earlier, is that it basically focuses on problems identified by your key interested parties. And that includes our learning communities of patients, providers, and healthcare leaders. It is also focused on developing the infrastructure to continue doing the work over time. So imagine you do an implementation study and you've gotten this awesome data where you have EHR data on your patient outcomes and provider outcomes, but then you sort of stop and then you essentially put that aside and do another study where you pull new data, and then you do even another study and pull new data. But imagine in the VA being able to have a data lake, a large comprehensive data set where you can run multiple studies and not just do one data set here, one data set there, a third data set here. The idea here is for Query to build the infrastructure using funding that would be providing for the learning community and the infrastructure to build common data that could repeat, and you can do piggyback studies over time. And then finally, it's also the idea that we provide implementation playbooks back to our key leaders and practitioners after we do an implementation study, like a hybrid type 3, for example. So all this is baked into the way that we think about providing support for implementation studies over time and be able to hand that off to key providers and also other interested parties. This is a very small map, but it shows our national network of query centers. We have 2 here. The 2 are led by Dr. Corinne Boyles and Dr. Nazia Safdar that are focused here. They're called Partnered Evaluation Centers or Partnered Evaluation Initiatives, and they're mainly co-funded by other operational partners. So it's a way of matching funding and be able to stretch the dollar even further to do learning health system work. And then the final thing I want to mention, here's another cycle yet again. We love cycles in VA since we like to see repeatable processes. It's baked into our high reliability way of thinking. But query in the last few years has been embedded in the VA's National Strategic Plan. The VA Strategic Plan, like every other government agency, basically tells what that agency, what they should be spending money on. And what it does is essentially basically provide a cycle format in which we identify a problem to be solved in VA. We provide an RFA or request for application for investigators to work on that problem. We fund the highest quality applications using peer review. We then have those projects produce a series of impact or findings, research, things like that. And that gets communicated back to VA leaders. And here's the key. They're communicated back to the VA finance leaders so that they use that to basically grade the level of evidence for any budget proposal that comes internally to VA. So VA gets an annual budget every year from Congress. It's a certain amount of money. Within the VA, they have to make decisions on what to spend in terms of programs and policies. That decision is now made based on research that is basically communicated by query into the VA Finance Office, and they make a determination on the level of evidence for every budget request coming through. So this is baked into the VA's national system in terms of being able to use evidence to inform practice. We were able to do this because we were pulled into helping the VA respond to a law that was passed in early 2019 called the Foundations for Evidence-Based Policymaking Act. And I'm really nerding out here about policy and stuff because I think policy is a really important point in terms of having our implementation scientists influence things. But basically, it's the idea that you should be spending money on things that are evidence-based, essentially. And it's, kind of duh to a lot of people, but it's, it's amazing what government does and does not do. But in any case, so how does query fund? If you're an investigator, how do you get money to do your project and what happens? So we have 3 phases of funding depending on essentially short, medium, or long term. So the query program is funded uniquely through medical care dollars. So technically we're able to fund quality improvement and research depending on the situation. So what we do is we basically think and help people to think about ways they can do rapid quality improvement, and that's within a year. So we have something called a rapid response team. And one example of a rapid response team was led by Ronnie Elway. And she designed a rapid study and evaluation on the COVID vaccine acceptance among VA employees and veterans, and basically rapidly collected information about attitudes and perspectives about the COVID vaccine as it was being rolled out in late 2020. And she was able to actually craft communication based on the findings of what she was basically hearing from people across the United States in terms of hesitancy or other issues, and was able to craft communication based on what she was finding. In addition, we also have something called again, I mentioned the Advancing Diversity and Implementation Leadership Fellowship programs, as well as programs that are called our Regional Network Quality Improvement Initiatives. And one example was led by Sonia Gabralian at the Greater Los Angeles VA, where she basically implemented, using a Type 3 design, a critical time intervention for homeless experienced veterans. And so looked at ways in which facilitation and other implementation strategies were helping frontline providers implement the critical time intervention for veterans experiencing homelessness and seeing to what extent that supported frontline providers. In addition, we have longer term initiatives called our partner evaluation initiatives. And one example there is basically a national evaluation of the Caring Contacts program. This is basically messages given to veterans who might be at risk of suicide, and are done either through a point of care or they're done at a population level. And it's basically designed to be non-judgmental and very essentially carrying communications to the veteran to make sure that they're doing okay and other types of communication. And that was actually been nationally evaluated and rolled out on the national basis, and not only among veterans enrolled in our VA healthcare system, but transitioning service members as well. So it's expanding to that. But all these are different types of funding opportunities Query provides. We have a budget that we provide every year, and we're able to peer review all these different opportunities and, again, quickly get investigators embedded into solving problems more rapidly for our operational leaders. How we measure our success is based on the Query Action Impact Framework. This framework is based on a series of other impact metrics, usually from the CTSAs or from the National Academy of Medicine and RAND. The idea here is basically we want to get beyond measuring success based on papers and grants. And that if we're going to measure success and make the case, especially to Congress, if we want to get Congress to give us more money, we have to basically ask, how are you improving care for veterans? Are veterans getting better? How many veterans are getting access to effective treatments? We just had a hearing yesterday, I think it was 2 days ago, and our Chief Research and Development Officer was asked questions. I mean, these are sort of questions we often don't think about because we're thinking individually about our studies, but she was asked, how many veterans are enrolled in clinical trials nationally? And essentially, and how many veterans are essentially benefiting from treatments that were tested by VA researchers, for example. So these big ticket questions were also asked by Query, and we were asked how many effective treatments were being delivered to veterans, and we actually estimated it was about 5.3 million. That's where we got our number. But this is essentially the types of impacts our key interested parties and stakeholders are interested in, and they ask us all the time. And this is something collectively, if we think about running a learning healthcare system, is that you want to be able to continuously collect this information and have this on hand, because that's the kind of information that will essentially allow you to get additional funding and resources over time. So some examples of recent Query impacts. I mentioned the Carrying Letters and Carrying Contacts program. This was, one of these was run by Sarah Landis, who was mentioned earlier, as well as Mark Rieger. And you can see here that they were able to initially promulgate this program to over 200,000 veterans and over 22 sites nationally. We've also had a number of impacts around opioid and pain treatment. One of the largest learning health systems we ran was essentially a multi-site national program where we provided to veterans both the step care for opioid use disorders and alternative treatments for pain, including physical therapy or cognitive behavioral therapy or other treatments as well. And so what we saw was the step care for opioid use disorder and, again, substitution with another type of pain treatment was close to a 300% increase in patients with OUD receiving evidence-based treatments for not just opioid use disorder, but for pain as well. And then also we just initially run the consortium to disseminate and understand implementation of opioid use disorder, or conduit, and basically at that point, the conduit is sort of like a mega multi-center. It involved like several integrated service networks, over 9 integrated service networks. We have 18 total in the VA. And over 7 evidence-based practices for pain were implemented across 60 facilities across these 9 regional networks. So that's essentially half the country. So again, I'll just mention one more time the learning hubs that we offer in Query. There are several of them. They focus on training researchers and clinicians on specific implementation and QI strategies. These are implementation change strategies that have strong evidence, or at least have some evidence that they've been effective in hybrid type 3 trials. They're managed by our Query Center for Evaluation and Implementation Resources, which is run by Nick Bowersox at the VA Ann Arbor. And they're also available through our website, and you can contact SEER for more information. But they're usually intensive, like 2 to 5 day training opportunities to learn actually how you use an implementation strategy for your research or how you use it in practice. And some lessons learned. So thinking about how Query was able to sort of support some of this learning healthcare system work and how we've really used implementation science. Basically, we made sure that we were embedded in key decision-making points in the leadership infrastructure in VHA. So for example, Query basically is rating the level of evidence of budget and legislative proposals that come to VA for funding, so that with this global budget, the VA is able to fund things that are evidence-based. We also have a data-driven consensus on the top priorities of local, regional, and national leaders. So every year we do a national survey and focus group of our local, regional, national leaders for them to identify what we should be funding. In addition to that, we also leverage research and clinical operational resources. So we basically leverage our research infrastructure through our national network of centers, as well as additional funding and data that we get from our operational leaders. So VA is a very interesting place where it's not only an embedded research program in a national healthcare system, we have a benefits program, and we actually provide national policy making at the national level in Washington, D.C. So essentially, that's where we have policymakers who are embedded in the VA who say, this is the level of mental health services to provide. These are the number of providers that each site should have. So they have like staffing ratios that they set and everything like that. It's very unusual, but at the same time, a wonderful opportunity to study how all these different functions work together or don't sometimes. We also provide training to demystify implementation and evaluation methods. So not just make it into an ivory tower exercise, but making implementation science work for practitioners, making the idea of doing evidence and evaluation work for veterans. And then finally, we basically collect impact metrics year after year about how we're making an impact on VA care. And in 2020, the Government Accountability Office published what we were doing in Query in terms of how we were measuring impacts on how we're moving the needle on getting more veterans access to effective treatments, for example. So basically, that was my talk on learning health systems. Happy to entertain any questions. Thanks so much, and really want to acknowledge my colleagues here. And then if you're interested, we also have more information here on our implementation strategy learning hubs, as well as our learning health system program too. Thank you. Yeah, Mike.
I'm sorry, we don't have time for questions.
We don't.
We do not, unfortunately. Danny is up next. But if you want to put your questions on the board here, we can make sure they get addressed during the course of the afternoon. I see one hand. Is that acceptable? Thank you. Sorry, we got a tight timeline this morning.
I would like to yield some time on the floor for questions for Amy Kilbourne.
Awesome. Thank you. Thank you, Danny.
Seriously. Does anyone have a question for Amy? That's like unbelievable what she's doing.
Since you're so vigilant about your time management and you're
I yield
checking,
the time.
we witnessed you do that. Thank you, Danny.
You're welcome.
I was really excited to see that your work included staff. Very few of our human population have doctoral level training. And at all levels, at all of our institutions, including our state, and the local, regional, and national government, we have non-doctoral people who are leading funding mechanisms, organizations. And I'm wondering, from the work that you are doing with staff, how can we encourage other institutions to be more inclusive of people who don't have doctoral level training, who need this training, who are not going to go get a doctorate degree to get it, so that then this work that's being done in the institutions, that research, can actively be translated, because now we're speaking a common language.
That's a really great question. So I'll just have to give a shout out to Melissa Braganza, who's my acting director for Query. I took on a new job when my boss retired, and she's master's prepared, and that's how it should be. I think that more and more times we need people who think broadly, and the strengths that sometimes, I think one of the strengths of having like a terminal degree, like doctoral degree, is yes, you get a lot of deep dive understanding of all the methods and things like that. But I love working with individuals who don't have that, because they have a broad perspective, a real world and lived experience perspective that you absolutely have to capture. So how do we encourage more places to do that? One of the things in VA we've done is actually, there's a term for it, but we've tried to tamp down what's called credential inflation. That no, you don't need a doctoral level position to run certain programs, and you don't even need a master's level type of degree. And I think in many respects it has to be done, because first off, college is getting really expensive. And I think a lot of people with real world experience don't have the time to go and get a PhD, and I don't even know what the value might be for certain types of skills. If you need to think big picture, you don't necessarily need that PhD or doctoral level degree. So we've really tamped down on the credential inflation, and we've changed the way that we've done a lot of our recruitment of our scientific program managers so that they don't need to have a PhD. In fact, we look for experience now, as well as our managers and leaders. So that's one step. And that was actually an executive order that was, I don't know if it's still around, but actually the government, the presidential executive order had that as a way across the government, federal agencies to stop making degrees a requirement for certain jobs in leadership. So that's one idea. And so hopefully that's something we can further promulgate across states as well. But that's sort of my suggestion.
All right. Any other questions for Amy? All right.